All right, so we're going to have Emily here from Relievant. Great thing about the new Intracept procedure is all three of us do quite a bit of it. Myself, Doug, and Chad will come right back in. Put that right there. It's not in the way. All right. So here we go. So,
Come on. This is Emily. Emily's my rep, not his.
I know this is
This is my house, man.
I had all my reps here last time in Fort Lauderdale. Now we have all the.
Oh, we have Doug Beal here. Where'd he come from?
Huh?
Doug's here.
There we go.
We got Doug too, so we got a great forum here.
He's done a few Intracept cases as well. So
this is Anthony's baby.
Yeah, I love this procedure. Brand new. I mean, I say brand new, but it's been on the market for over 2 years now, 2.5 years. Yeah, I mean, the studies are all the way back to 7 years. So it's interesting in medicine, the ball rolls slowly for a lot of patients out there. Do I still call this a new procedure? I guess I do, but it's been 7 years since the first case. Yeah. So in my mind, that's not that new. And one thing that we've talked about with some of the other procedures is data. And the data on the Intracept procedure just keeps getting better. I don't think many people have seen that. Even from, the first cases to commercialization, the data keeps getting better. People are getting long-term durable relief, which in the field of pain, there aren't many other procedures we see that with. So I'm going to roll through some of the slides here like we have with the other procedures. So which patients does this work for? For all you doctors out there or even patients that procedure, you only need 3 things. You need to have chronic lower back pain of at least 6 months. So that's that axial lower back pain. Failure to respond to 6 months of conservative care. Before all of these procedures, you want to try conservative care. Therapy, anti-inflammatories if the patient can take it. That's always the first place to start. We always recommend that. Being PM&R trained, I love therapy. I think it helps out a ton of patients. I think you should even push your patients a little bit to try it. And then you need to have an MRI that demonstrates type 1 or type 2 motor changes. We talked about type 1 and type 2 motor changes a little bit when we were doing the Vivex procedure.
Yeah, we did.
Same kind of concept. So on T1 weighted images, you're going to see a hypointense for motor type 1, and type 2, you're going to see a bright signal. And then on type 2, it's going to be bright on both of them. The best way I tell people that don't read all of their own MRIs, you have to start looking at your own MRIs. You have to. This is another thing that a lot of radiologists won't say modic changes. They might say edema or something along those lines. That works to get insurance approval, but you might miss that, if you're just reading through it real quick. So always look at your MRIs. You'll start noticing, they'll start popping out to you because modic changes sometimes are subtle, but a lot of times, boom, right in front of you. The best way to know the difference between modic type 1 and type 2 and type 3, which this is not indicated for, type 1 and type 2 are both bright on T2 images. So if you see something bright on a T2 image, it is a modic change that can be treated with the Intracept procedure. So once we have those patients, and these patients are in your office, I estimate around 10% of patients that have chronic lower back pain without radicular pain do have modic changes, and that's what the data has been showing. Contraindications and risks, this isn't a training, so we don't have to go through all that, but it is always good to know. You have to know that with any procedure you do, what can go wrong? How can I be hurting the patient? Do no harm. That's in our oath, right? So you want to know what those risks are, what those contraindications are. The nice thing with this procedure, the risks are very minimal. Minimally invasive procedure, no overnight stay in the hospital. I don't even put stitches in these patients. It's just a little poke hole the size of this needle. There are some contraindications though, spinal lithothesis, which we have another procedure for that we'll be talking about. Patients with radicular pain, it's not a contraindication, but it's not going to help that. So right tool for the right patient. If someone has florid radicular pain and only a little bit of back pain, you might want to think of going another option. Also, one other thing that I always tell people to look out for is osteoporosis. Since we are going into the middle of the vertebral body, which you'll see with these slides, you just want to watch out for it. You want to maybe get a DEXA scan if you're not sure, but I have done these on patients all the way up to the age of 80 and haven't had any problems. I'm not sure about you guys.
So it's unimportant, really. I mean, it's relative contraindication with the emphasis on relative, because most of the people with stable discogenic back pain, modic type 1 or type 2 changes, what's the other option?
Exactly.
Well, really nothing. People infuse these, and Yavin Yoshihara data says that 2/3 about of the infusions are done, even though they should be done on scoli and spondy, they're done on stable discogenic back pain. And for the patients here, just a quick what you can give your patients, what I tell patients based on SMART trial, Fisherman's data and the Intracept trial that was recently published, I give them the rule of 75% response rate. Usually the pain is reduced 75% and it's durable or permanent, because the last paper that was published on durability, my first case is 6 years out now.
Yeah.
And so, the data is 6.4 years on the average and still going. So this appears to be, unlike other radio frequency ablation procedures, appears to be permanent.
The nerve does not grow back. That's one thing I tell my patients. They ask me, well, when do I have to come in and do this again? Because a lot of people have heard of ablation.
That's right.
That's a different type of ablation they're most likely
Very
talking
cool.
about. I tell patients at 6 weeks, wherever you're at 6 weeks is where you're going to be. If not better, why do they get better? Because they no longer have that back pain. They're able to lose that extra weight they put on. Their mindset is better, and their back pain continues to go down. They're able to do therapy now. So some of the data is very impressive that's out there. So like I said, it's a minimally invasive procedure, targets the basivertebral nerve. And where is that nerve? That nerve is right in the middle of the vertebral body, comes off the spinal cord, goes a little track outside of the spinal cord, and then kind of dives back in and dives straight through the posterior part of the vertebral body. Key benefits we've already kind of talked about. Treatment options once conservative care fails. Minimally invasive outpatient procedure. This procedure, each level takes 25 minutes to a half hour. Let's say we're doing 3 levels, hour and a half at an ASC, an outpatient center, go home the same day. I don't give any post-op medication for this. I say take a little Tylenol and ice the area. What hurts the most is usually just the skin site where I punctured through. Implant free. I always tell my patients, I'm getting in, I'm getting out. I don't leave anything behind. I'm not taking anything out. All we're doing is getting in and burning the nerve. I'm not taking out any of the bone like you would with a laminectomy. With a fusion, I'm not leaving screws or rods in there. There's no adjacent level issues after you do this procedure like you see with the fusion. And it has an excellent safety protocol. Here's all the thing we have. So this is the meat and potatoes right here. This is the generator. We burn up 85 degrees for 15 minutes per level. And while you're burning, some docs might think out there 15 minutes, that's a pretty long time. It's okay. While you're burning the one level for 15 minutes, you're able to start on the next level. I usually alternate back and forth, left, right, in order to do that. Also, these are all the tools right here. This is all you're going to need. You have a trocar, you have a diamond and a bevel tip. The bevel tip is nice. You'll see. We'll see how easily I get in through here, but hopefully it goes very smooth. I don't have to use the bevel too much, but it gives you some directionality. Let's say you're heading a little too medial in the pedicle, which could be dangerous. You're able to, flip in the bevel, go lateral, push medial a little bit.
It's like driving a needle.
It's just like driving a needle. It's really no different. This is their tool that really makes it easy to get to where the basivertebral nerve lies. So where does that lie? It lies 50% from superior to inferior end plate, and it lies 30 to 50% between posterior and anterior of the vertebral body. Now, when we're doing a kyphoplasty, which this is very similar to when you start, when we're doing a kyphoplasty, we're just trying to get into the middle of the vertebral body,
That's right.
right? And actually, we go all the way anterior, right? We always go all the way anterior. We blow up the balloons. We put the cement in, maybe pull back a little bit. But with Intracept, you have to be perfect. So I train Intracept, and I always tell people, I'll let you go first, but you have to be perfect. So instead of going right down the barrel of the pedicle straight down, you want to start from superior lateral to inferior medial, because that'll give you the best track to get to where that basivertebral nerve lies. So we go down through the pedicle, and actually we have some slides here I can go through too. So we access the pedicle, just like we do at a kyphoplasty. AP lateral, make sure we're going in the right direction, make sure we're safe. That's the most important thing, right? Once we access the pedicle, we take out the trocar, put in the curved cannula that has nitinol on it, so it bends very nicely. We get that down. This is the hardest part of the procedure, is getting this in. Let's take this off and do it the other way. So there's a new trick where you can put the straight stylet into the curved in order to get it through a little easier. I always say the guys that were trained before that are hardened. Is it bending it? Do you have any saline?
It's not very wet.
Yeah, we can just put some saline through it. But we get the curved in there. This is the cutting tool in the curved cannula. And what we do is after we get into the pedicle, we curve around right to where that basivertebral nerve is. We take this out. We put in the probe, which RF probe. And like I said, hook it up to the generator. You hand it off to Emily, or my rep is Aubrey or Paul. You hand it off to them. they do the rest of it, and we're good to go. So we'll talk about some of this data we talked about a little bit. This is kind of what Doug was alluding to, where 66% of the patients are getting at least 50% pain relief. And why is this important? It has to be, we all talk about these VAS numbers and ODI numbers. What matters to me is, does the patient notice a pain relief? Down in South Florida, everyone plays tennis, everyone plays golf, everyone's boating. Yep. Are they able to get back to do what they love without a huge invasive procedure? Yeah. And this procedure is getting people back out on a boat. You think if you have back pain and you're hitting waves on a boat, every single wave hurts. You're trying to play golf, every single swing hurts. I mean, I had a guy that just came in 2.5 years post-op, snowbird, he goes back and forth. He showed up. I was like, oh, are you okay? Yeah. He goes, yeah. He goes, I'm great. And he was one of the first patients I did for Intracept. He goes, I'm great. He goes, I have some hip pain. That's why I came back to you. Mm-hmm. He goes, I can't tell you how much you gave me my life. Yeah, it was awesome. And that's the most important thing, is it's such a quick, simple, minimally invasive procedure where we're not burning any bridges for any other procedures, that the data shows it really gives people their life back.
You make a good point there. You'll notice on our social media, we use a lot of testimonials. And rather than that, we call it a patient success story. Testimonial sounds like, I want you to do this, I'll pay you to do this, please do this. A patient success story is a patient that says, what you did for me changed my functionality so much, I want to tell the world.
Yeah.
And so if you'll go to their website, Intracept's website, we just did a patient, Dave Herpendahl. Dave was a patient of mine who just wanted to be able to live his life and mow his yard and not even do everything in South Florida. I mean, he lives out in the country, right? But the fact is, there's a beautiful testimonial where Dave did a fantastic job of explaining his situation. And so I think you'll find some testimonials. Really, that's what it comes down to. The reason we do those testimonials is because we want our patients to tell other people. If we say it, it means something. If they say it, it means everything. And so we use a lot of our patient testimonials to get the word out to communities. I don't know if you realize this or not, but if you want to be shooting what you do out to a certain part of your community, you can put those zip codes in a certain age range, and they can shoot that to them. So again, Moxie has done a great job for us getting the social media in, especially during COVID times, where you can't even go into another doctor's office and meet with them. You can always have them get on their social contacts and use their media. So I just want to really encourage you guys to add that to your practice.
So one of the things that Anthony said previously about being spot on, I want to emphasize. So in the SMART trial, the single greatest predictor of outcomes and success was the ability to target that basivertebral nerve.
Yep.
So if you look back at the case failures, and we always want to make ourselves better, the case failures overwhelmingly had mal-targeting of the nerve. Yeah. The nerve was just missed. So the nerve is located, as you mentioned, 60% of the way from front to back, plus or minus 10%, half the way up. And targeting that nerve is not easy. It's moderately difficult. So this is okay if you have to take a few passes, but be accurate, because you know that the more accurate you are, the better the success will be. And also in terms of this, the nickel titanium stylet is also curved. It's also beveled. It has a bevel this way, so it exaggerates the steering capability. And the ability to get this through the needle, place your thumb and bend it up and turn it in like this. Also, for stable discogenic back pain, you're competing against what? Fusion surgery. So here's some stats. I gave you 75 durable or permanent. Based on the Fritzell Swedish registry, you've got a good to excellent surgical outcomes, 33% reduction in pain. So it's more than twice. It's 2.5 times better than that. It's also 4 to 5 times cheaper. And if you compare to give you some more Ermola data, so somebody that has a fusion for whatever reason, so takes 6 weeks to recover from, you're not yourself again for a year, and 20% of those patients will have repeat surgery within 4 years after the fusion surgery. So this fills a gap, fills a space that there's really no competitors. And my buddy from Jersey said that I talked to him this morning, it's 3 whacks in the back, right? Meaning 3 epidural injections and a fusion surgery, which is absolutely unacceptable. So this helps to fill the no man's land.
This adds in that gray area between surgeon. And one reason I know it works better than surgery is my surgeons don't want to do those surgeries, because those patients don't do well. They want me to do this. Most of my patients I get for this come from my surgeon. So I'm a little different. I'm not sure about you, Doug, but I work directly with 14 surgeons. I'm the only pain doctor.
like a
There's
dream
some
world.
there's some procedures that come into the pain world, and the surgeons get a little wary. They
Yeah.
say, I don't know if you should be doing that, because there is that gray area between interventional spine and spine surgeons. This procedure came out, and they're like, yes, do it. And one thing my surgeon says, we actually give a presentation together when we're going around down in South Florida. He says he Aiken's doing a fusion for a patient like this, like doing a fusion from the hip to the knee because of knee pain. Yeah, your pain will go away because you're not moving the knee anymore, but that'd be barbaric. And they used to do that back then. You still have a stable leg to walk on,
Wow.
but that'd be insane. No one would do that now. So to do fusions for this type of injury, to me, is outdated. So I think we're through the slides. Just to recap, 2 level 1 RCTs. I mean, you don't see that much. Treatment effect, durability beyond 5 years on from control rad. It's going to sneak by there. You're gonna meet him next. He's gonna hit the button for us. So where do we start? I'm gonna do L4, right? So this time we're doing it straight down the vertebral body. No, we don't need serum. Oh, look at that hammer! That's a nice one. You want to get a decent sized hammer. One other thing, I'm going to compare it a lot to kyphoplasty, just because a lot of people have done kyphoplasty, so they can wrap their mind about it. These are younger patients. We're not doing this in 80-year-old patients with osteoporosis and fractures. These are younger patients. Their bone may be a little bit harder, and actually, Relievant has come out with a drill that you can use as well. But you want a decent hammer. So we'll start with L4. So take a shot. Tilt the head a little bit. Once again, same kind of concept of doing the disc. You want to line up the end plates, and you're going to come south a little bit, please.
If you're watching this, remember that you can take your Immertech headset and you can take the little laser and you can make big anything you want to see.
So the C-arm.
Go to the C-arm picture right now and you'll be able to see
we have
what
this camera right here that we're using. You can see the hammer on. Okay. Up to the head a little bit more.
All your patients will have pedicles that look just
I'll just
like
do
that.
one right there. That's great.
It's
So
mandatory.
yeah, these are beautiful pedicles. If I screw this up, I'm not gonna hear the end of it. Between Doug and Chad, if I screw this up, it's gonna be bad. After
We're gonna take you out and shoot you. That's what we do in Texas when somebody doesn't do well.
That's good. I'll do that for you. So there's different techniques to get started. Like I said, this is an education combine. It's not a training. You're not. I'm not going to go through every single step for the sake of time.
Yep.
But some people do like to oblique and go and just to get an idea of where to start. What I do is kind of go 1 or 2 inches past the side of the transverse process. Yeah. So right there, you can see my needle tip coming in. I got really lucky there. Well, the BioTrust model helps, but I know where I'm going.
You can see it.
Shot again. So, and once again, when I dock on that pedicle, I want to be on the superior lateral aspect, not right in the middle of it, because I need to get medial the second I get into the vertebral body. If I'm all the way out lateral through the pedicle, you're not going to have time to turn around. You're going to chew anterior. You're going to be more than 50% from posterior to anterior. You're going to miss the nerve, and you're basically not doing the procedure. The patient's not going to get relief.
So what Anthony's telling you guys, in case you're missing the point, is with kyphoplasty, you come in at a lot greater angle. It's critical with this that you drop your hands substantially and come in at a much less oblique angle.
So I'm going to work my way down that pedicle. A lot of times what I want to do is I have my rep stand at the end of the table. Take a look at what that angle is. I want my trocar to be at least 45 degrees from the spinous process shooting up towards me, at least. Because that'll help me make the turn.
Emily's great at math, by the way. She gets out her ruler and she does it. She's amazing.
Yeah.
It's like trigonometry class with her.
Very amazing.
So far, so good.
Okay. So I'm going right down that lateral aspect shot. Right there. So I feel the bone. These BioTrust models are great. I get that feedback. I feel the bone. I mean, that's pretty perfect. What do you guys think? That's a good place to start.
You're doing good so far.
So far. Okay, I'll take
Verdict's
that.
still out.
They beat up the young guy. So we're superior lateral here. A lot of times, I'm going to check a lateral at this moment, make sure I'm not on the pedicle, make sure I'm not on the facet or something along those lines. Once again, your patient's not going to look this good. If they are, you shouldn't be doing any procedures. But for learning purposes, this is the way to do it. Do 10. We can literally do 10 Relievant cases here if we want to, no problem. So I'm going to tap through. Nice and hard. We're going to have to hit this. So we're working our way through the pedicle. I'm a little high. I'm going to So we went a little medial
Yeah.
through it. Let's see where we're at laterally.
A multi-talented Lindsay with 5 extremities. It's good. I mean, it's hard to get somebody to sign up. You saw what happened to the rad tech in our last combine. It's hard to get people to sign up for this, you know what I mean?
No, it's
We almost took them out with that projectile, remember?
yeah.
Yeah, we'll say, you guys know what I'm talking about, don't you?
Yeah.
That was fun.
We got it. So normally you want to work your way slowly down the pedicle. But I'm,
That's perfect.
I nailed it. So I just want to,
to,
for the sake of time, I went really quick.
That was really good.
But you want to go slowly down the pedicle. You want to make sure AP lateral, check at least 3 times while you're going, because you want to make sure that you end up right at that posterior aspect, right when we're on that medial border. So
Perfect. Absolutely
it
perfect.
really is. I'm a little high, but I can use the
You can
curve.
adjust that.
I can use the curve to get down a little lower, so I'm going to go through a little bit more. Shot. Go through the posterior cortex there. Perfect. I'm going to pull out that straight cannula we talked about. I'm going to try to get this curved one in. Oop, we got a new one. Let's see, I think this is a muscle thing, so it might be a me problem.
We talked about training for combine. I think you
Oh,
did
there
that
we go.
seriously.
That's nice. That's nice.
I got one warmed up for you.
You did. Thank
Good
you.
job.
Thank you.
Excellent rep work.
So
Good job.
before we
Make your
seat
doctor
it
look
in,
good.
and you'll get this when you get to your training. This is not a training, this is an education. You're gonna want to do a training though. You're gonna call Emily. You're gonna reach out to your Relievant rep in your area. You're gonna write your hands on this, but just some little tidbits I will give you so you can think about it when you get to your training. So I think we can see where I point here on the CRM image. You can see this curved cannula going through the trocar. And see how it's bending right now? So I want to go a little bit down. My target point is right here.
Yep.
That's 100% where I want to end up. I don't want to be here. I'll miss the nerve. I don't want to be here. I want to get the top part. I don't want to be here. I want to get right in the middle here. So I'm going to want to curve down a little bit. If I wanted to go straight, what I would do, see how that straightened out that curved needle going down through? So now that would go straight and come right here and about here. So I want to go a little bit towards the feet, right there. That's going to take me right where I want to go. I'm going to seed that by popping it in, and everything's pretty foolproof. They have it all set up. Relievant guys,
It's like being a child playing with a toy.
shot. That's a lot with what we all do, right? Shot. We're going to spin up the red wing now, which is the only reason my rep comes is to remind me to do this.
Clockwise or counterclockwise?
Clockwise.
Yeah, there you
They
go.
are coming out with a new one, so you don't have to spin it as much. That's a workout too, getting that all the way up.
It's a Dr. Stevens proof.
So now we're going to try to see if we can maybe even a little more towards the feet shot. So see how that curved even
Yep,
more?
yep.
This is a great spot to be looking at your CRM image shot. There we go. This is perfect. So we're going right where we want to go. Shot. Going a little south. It's starting to make that turn. How do I know that? Because we see the paddle there that I think Doug alluded to, the cutting edge. This cutting edge is starting to shorten a little bit. So that means if you think about it in a 3D picture, it's starting to come at the C-arm. So it's starting to go straight into the C-arm, which means we're going medial. Once again, for the sake of time, I would be checking an AP and lateral as I go through here more often, and you'll do that in the training. Shot. This is looking
It's
really good.
important to say that you only take a little thread at a time,
Yeah,
2 threads at a time, so you can make adjustments.
And you'll actually see what I'm doing is I'm keeping my finger under here so it can't go too quickly. You have someone with osteoporotic bone, it might just shoot through and not go where you want to go. My finger is a stop, so I can't get in there. And when I get to the end, I put my pinky under there. Let's check an AP, see how far we made it. So we need to make it, I didn't talk about this yet. We need to make it 50% from pedicle to pedicle in the AP view. So that's right where we want to be with the nerve, blade the nerve. Okay. Wow. So that's it.
Let's see.
So I'm going to take it a little bit further. I want to take it a little bit past the middle.
Just a little bit off on the C-arm, just a little bit. Yeah.
So, and that's a great point. We want to make sure that it's exactly an AP. So see this pedicle's over a little bit more. So she's going to oblique a little bit towards us. So I have a little bit more to go. So that's one place you can get a little trick is, since it wasn't a perfect AP, I have a little bit further to go. But we know what the lateral image looked like. We know I had more room. I'm not going to end up too anterior, so I can just take it from here. Can you just raise this arm a little bit? Shot. We're making our way across. Shot. Boom. That's right where we want to be. I could probably take it a little further. Perfect. And yeah, bro.
No,
That's
it's
fine.
not.
So at this point, we would take out the curved cannula,
Flick blood all over everybody
Flick blood.
around the room.
and this is the straight stylet. What do we use this for? This is for if we haven't made it all the way medial. This happens a lot at L5 and S1. They're wider vertebral bodies, or you have a big guy, muscular guy. They do have wider vertebral bodies than little old ladies. So this helps you get across further medial when you run out of room with the curved cutting knife. So I'm gonna put this in just to show where the ablation would be. Shot. This has a radial opaque tip that you can see there, the little dot. So that's right where we put the probe. The only difference with the probe would look like is there's two poles in the probe. There's a distal end and a proximal end, and that's where you're going to be burning. So this would be the distal end. There'd be another little line that shows the proximal end. So we know we're in the perfect place here. We're 50% from superior to inferior. We're 50% in the AP, and then let's just go lateral for one more shot and show that we're not more than We'll see. This is I think we're good. This is the moment of truth, though, to show that we're less than 50% posterior to anterior. And when we're in the trainings, I'll tell you, if you end up anterior, there's no way to fix it. You got to go to the other pedicle. I've tried. That's perfect. So we're less than 50%. Can you go down a little bit more? Just so we can see the anterior part. Perfect. So here we go. When we're measuring from the anterior portion of the vertebral body to the posterior, we are less than 50%, which is probably right around there. This patient's going to get great relief. We're right in the middle. We're exactly where we want to be. Very impressive procedure. Emily, do you have anything else to add, or anyone else?
No, I think you pretty much hit on all of the important topics. And
Yeah. I mean, to me, being a young physician coming out of fellowship, this was one of the procedures that differentiated me in my community. There's a lot of pain docs around, and I was the only one in Florida doing this at the time. And, it's something that you want to have in your tool bag. You have to have this ability for the patients.
Essential. This is essential. So you have discogenic versus vertebrogenic pain, modic changes, vertebrogenic pain. Discogenic pain tends to be younger people. Your prototypical is 30 years old, internal disc disruption, debilitating back pain. That's a different scenario. For vertebrogenic pain, it tends to be discogenic back pain associated with modic changes. And this is not a zero-sum game, right? Yeah. So everybody with internal disc disruption, discogenic back pain, they'll graduate on to have vertebrogenic pain and degenerative end-plate changes, named after our friend Mike Modic. But these are the same. These are synonyms. But what else do you do for stable discogenic vertebrogenic pain? You have to have something for it, because as Anthony mentioned, the surgeons don't want to fuse because the outcomes are poor. And we know this. Fusions for unstable spine and scoliosis, not for stable discogenic vertebrogenic back pain. So if you're thinking about this, think hard, because once you accomplish this and have the ability to treat patients with this condition, you'll realize that BVN ablation is absolutely essential.
Awesome, guys.
That's great. I think
That's great. Emily, thank you for coming and bringing everything. Your reps have been great today.
Yeah, hey, you know what? I only bring the best.
You brought the all-stars.
Yeah, they've trained me well, right? I mean, I've trained them. We all work together.
right.
You're the one getting trained.
Yeah, Anthony nailed that, made that look super easy. It is easy. As far as technically, it just takes a little bit of work. If you're a Kypho user, you know how to get across the pedicle.
Yep.
Just minor changes, but I mean, he made that look perfect. And so
you don't get down the pedicle as easy as I did, but it takes a little work, but anyone out there can do it. Anyone out there that's used to going down the pedicle can do this procedure. Get trained, talk to your Relievant rep. You have to have this in your tool bag. You have to.
100%.
Very good. Awesome.
Okay.
Thank you.
Let's keep going.
Good job.
Great.
Good job. Good for being here.
Ask questions.
We have some questions?
Who's next?
Go ahead.
Adrian wants to know, how do you trial this?
How do you trial this? You don't.
So
You don't
everybody
need to
trial. You don't trial. Everybody that I do this on, I do discogram, anesthetic discogram.
Yeah.
And they have to be concordant. So I do test first, usually with anesthetic discography.
Yeah, you don't have to do
Don't have to.
I do in some patients, but
Yeah.
just to be more sure if we're going for the right thing and the patient gets relief.
Based,
To me, that you need the three things I talked about: 6 months of chronic back pain, 6 months of failed conservative therapy, and modic changes on MRI.
Exactly. Based on the Intracept and SMART trial, it's done by VIS only, by visualizing the degenerative vein plate changes and the levels 3 through 5. So you don't have to test for it, but I do. It gives an added benefit and a chance to improve from a simple disc injection.
Perfect. Any other questions? Right?
Oh, wait,
Okay, great. Awesome.